بسم الله الرحمن الرحيم. Standards for treatment. The standards are from International Standards for Tuberculosis Care ISTC second edition. The standard 7 practitioner responsibility. Any practitioner treating a patient for TB is assuming an important public health responsibility to prevent ongoing transmission of the infection and the development of drug resistance. Standard 8 TB treatment. All patients who have not been treated previously should receive an internationally accepted first line treatment regimen using drugs of known bioavailability. The initial phase should be consisted of 2 months of isoniazid INH, rifampicin, pyrazinamide, and ethambutol. The continuation phase should be consisted of isoniazid and rifampicin given for 4 months. Fixed dose combinations of 2 isoniazid and rifampicin, 3 isoniazid, rifampicin, and pyrazinamide, and 4 isoniazid, rifampicin, pyrazinamide, and ethambutol drugs are highly recommended. Standard 9 treatment adherence. To foster adherence, a patient centered approach based on the patient's needs and mutual respect between the patients and the provider should be developed for all patients. Supervision should be individualized and should include patient counseling and education. Appropriate incentives may also serve to enhance treatment adherence. Standard 10 response to therapy. Response to therapy in patients with pulmonary TB should be monitored by sputum microscopy, two specimens, at the time of completion of the initial phase of treatment, 2 months. If the sputum smear is positive at completion of the initial phase, sputum smears should be examined again at 3 months. And if positive, culture and drug susceptibility testing should be performed. In patients with extrapulmonary TB and in children, response to treatment is best assessed clinically. Standard 11 drug resistant TB. An assessment of the likelihood of drug resistance based on history of prior treatment, exposure to a possible source case having drug resistant organisms, and the community prevalence of drug resistance should be obtained for all patients. Drug susceptibility testing should be performed at the start of therapy for all previously treated patients. Patients who remain sputum smear positive at completion of 3 months of treatment and the patients who have failed, defaulted from, or relapsed following one or more courses of treatment should always be assessed for drug resistance. For patients in whom drug resistance is considered to be likely, culture and testing for susceptibility resistance to at least isoniazid and rifampicin should be performed promptly. Standard 12 treatment of drug resistant TB. Patients with a highly likely to have TB caused by drug resistance, especially MDR or XDR, organisms should be treated with specialized regimen containing second line anti-TB drugs. The regimen chosen may be standardized or based on suspected or confirmed drug susceptibility patients. At least 4 drugs to which organisms are known or presumed to be susceptible, including an injectable agent, should be used and treatment should be given for at least 18 to 24 months beyond culture conversion. Consultation with a provider experienced in treatment of patients with MDR or XDR tuberculosis should be obtained. Standard 13 written records a written record of all medications given, bacteriological response, and adverse reaction should be maintained for all patients.